and good evening to all. Myself, I am Nitin Gupta, and welcome to the first Friday CME programs of the Indian Association for Biological Psychiatry. Today, we have got a very interesting topic with us related to psychosis in older adults. And I've got the pleasant duty of doing the introductions, where I'll be doing the introduction related to the chairpersons for today's topic. And then I'll be handing over to our chairpersons to introduce the speaker for today and then conducting the program. Our chairperson for today, Jillani A Q. She's a senior consultant in geriatric psychiatry from Mehta Hospital, and she's done her. She's specialized in geriatric psychiatry, and she's a fellow of the Royal College of Psychiatrists, having done her specialized training in geriatric psychiatry from the UK, and trained in London and worked as a consultant in Lancashire up north. So it's nice to learn about that, because I also worked in the UK, though I was in the Midlands. So welcome, Dr. Shiba. And additionally, we have got Dr. Pramod, who doesn't need much of an introduction. I would say that because we have been colleagues for, I've forgotten, probably more than 25 years, and a very dear friend of mine, very well-known speaker and practitioner in up North India, and is working here in Chandigarh, and has a variety of interests, but especially so in telepsychiatry and psychopharmacology, and substance abuse, along with geriatric psychiatry also. With this brief introduction of the chairpersons, I will hand it over to both the chairpersons to introduce the speaker and to conduct the session, please. Over to the chairpersons.
Can you hear and see me?
Yeah, can hear you.
Okay, thank you. Okay, thank you. And I first of all thanks Dr. Jillani and Dr. Shiba to be my chairpersons for this program. In fact, my duty is to introduce the speaker and a little bit about topic. But you know, in this, when I heard about geriatric psychiatry way back in 1993, when I was a junior resident in PGI Chandigarh, so I still remember Dr. Tiwari. I still remember him, because that is a time when people were not even aware of a geriatric psychiatry as an independent branch or having specialization in this area. And we thought, okay, this is such a very minuscule area of the psychiatry practice. But over a period of time of my residency and then 23 years of my prior practice, this is an area which is an independent psychiatry, I would say. It's a huge population with variety of problems and a very distressing problem with limited solutions, I would say. So Dr. Jillani is a pass out, is a resident from, done his residency from KGMC Lucknow, and he worked very closely with Dr. Tiwari, I remember. And then he has done his, not only residency, he has done his specialization in geriatric psychiatry, then followed by secondary DNB, which I don't know what is secondary DNB for that matter. I understand DNB, okay. And he has got a wide number of publications, very with good impact factor and good publications. And he has been a recipient of international awards in social psychiatry, World Psychiatry Association Travel Awards. And he has a numerous publications, and being a Indian Psychiatry Society then fellow, and he has been in the committee on geriatric psychiatry. And very promising, I would say, CV he has. And similarly, although Dr. Nitin has already introduced our chairperson, Dr. Shiba, I was going through her profile and just hearing it's such a nice, wonderful, full of academics, full of experience. I think both of them have a wide experience in this particular area, India and abroad as well. This particular CME, I think, is going to be a very, very enriching for the people who are attending this program. And I'm especially interested in this particular area for in geriatric psychiatry. So with this, I hand over to Dr. Shiba for her for her introduction and brief comments about the topic. Thank you. Over to Dr. Shiba, please.
Good evening, everyone. Thank you, Dr. Pramod, Dr. Nitin, for that lovely introduction. And I'm very happy to be here before all of you. So just as both my colleagues have just mentioned, psychosis in the older adults is a topic of discussion today. Any topic pertaining to the older adults is of extreme importance in this climate with regards to the population, and as we all know, with regards to longevity all around the world, specifically India, which is kind of growing with regards to its numbers and the older adults. And so it would be of utmost importance for us to hear what Dr. Jillani has to present today. Without further ado, I now hand over the to Dr. Jillani, and we will take over the question session. Thank you.
Thank you, the chairperson of the CME, Dr. Sir, and Shiba Nitin. Thanks for giving me the opportunity to speak the first CME of Indian Association of Biological Psychiatry. I'm really thankful to the office bearers of the Indian Association of Biological Psychiatry, the president of PUC and the vice president, Dr. Pramod. Also, I would like to thank Dr. Ruksida Shayeda, who is the honorary secretary of this organization. And with the permission and the convener of the CME, Dr. Nitin Gupta. With the permission of the chairperson of today's CME, I would like to start this interesting topic, which has been given me. If the chairperson would allow, I will start the CME. Hello, I am audible.
Yes.
Okay. Good evening, everyone. This is the very important topic as said by both the chairperson, Dr. Parmod, sir, and also Dr. Shiba. The elderly population in our country, not in our country, worldwide, are increasing. Currently, the population share of the elderly in India is 7% of the population, and that is a very huge chunk of this particular age group, above 60 age group. And the mental disorders were ignored for the elderly for a very long time. And in this mental disorder, the psychosis is very important. The current topic of today is the diagnostic dilemma and management challenges in elderly, especially if they have the psychotic symptoms. First of all, what is the psychosis? We all know psychosis is just a group of symptoms, psychological symptoms and behavioral symptoms, and which is usually associated with the loss of contact with the reality in the elderly. And there are the 5 types of psychotic symptoms. The most important are hallucination, delusions, negative symptoms, psychomotor alteration like the catatonic excitement or catatonic retardation or disorganized thinking, thought disorders. These 5 domain of symptoms of thoughts and perception make the psychotic symptoms. And these causes the alternation in the higher mental function, especially the thoughts, impaired memory, impaired intelligence, impaired judgment. There is the change in the abnormality of the emotional responses. There is the abnormality of the communication and the behavior. But these are not these psychotic symptoms are not a pathognomic of any particular either psychiatric disorder or non-psychiatric disorder presenting as a behavioral disorders. This is not specific to either schizophrenia or any other another psychiatric disorder or any organic mental disorder. That means why I am emphasizing on this particular line that this is not a pathognomic science. This indicates that the psychosis in elderly, either in the elderly or in the adult, could be symptoms of either many of the psychiatric disorders or many of the non-psychiatric disorders. In the adult age group, psychosis are generally associated with the underlying psychiatric disorders, whether it may be a schizophrenia, it may be a schizoaffective disorder, it may be a mood disorder with the psychotic symptoms. But in old age, in most of the cases, these psychotic symptoms are not associated with the underlying psychiatric disorder, like schizophrenia in the adult or like depression in the adult. Here in the elderly, these psychiatric disorders are basically associated with the either with the any organic mental disorders, any infection, any metabolic disorder. I will come later. Hence, the another important question, whether the psychotic symptoms are more common in elderly population than the younger population. In the younger population, the psychotic symptoms are basically associated with underlying disorders. But in the older adult, despite the underlying psychiatric disorder, there are a lot of number of physical, medical disorder which causes the psychotic symptoms. That means the answer of this question is yes. The psychotic symptoms are more common in elderly population. This is because there is the greater incidence of secondary causes of psychosis among older adults. It is seen in the wide range of psychiatric and physical condition. And above all, the most important risk factor for the risk factors of the psychosis is aging itself, because aging is associated with whether normal or pathological neurodegeneration with the compensated cognitive result. That means aging is the important factor for the psychosis in the elderly, besides a number of psychiatric and physical conditions. What increases the risk of psychosis in the elderly, especially the aging? The first is there is the age-related cortical atrophy, neurochemical changes. There is the cognitive decline with the aging. There is a number of comorbid chronic physical illness in the elderly. There are the several studies and most report in more than 50% of the cases of elderly, there is the one or more than one comorbid physical illness. That means when they have the comorbid physical illness, there will be the polypharmacy in the elderly, along with the treatment of physical illness and one or more physical illness. Also in the elderly, after the retirement, after the person becomes weaker with the aging, there is the social isolation, there is the sensory deficit like the visual impairment, like the hearing impairment, and the less important factors, risk factors are the genetic predisposition as in the younger age group and the premorbid personality as younger age group. What I am to say, there are the several risk factors which are associated with the aging and which make a elderly patient prone to develop the psychotic symptoms. Coming to the next slide, when there are the psychotic symptoms in the adults, what would be the diagnostic workup? Because there is the diagnostic confusion. In the younger age group, when the patient presents with the psychotic symptoms, when we delineate whether psychotic symptoms are in the form of hallucination, delusion, or other, and when we search for the primary psychotic symptoms associated with the psychosis in younger population. But here we have to divide the presence of psychotic symptoms in those groups, whether this psychotic symptoms are a part of primary psychiatric disorders or whether these psychotic symptoms in the elderly are presentation of non-psychiatric disorders. In the primary psychiatric disorders, they range from the schizophrenia up to ATPD, or there may be the schizoaffective, which are very rare presentation in the elderly. or there may be the other psychiatric disorder with the psychotic symptoms. For example, depression, major depressive disorder with psychotic symptoms, or mania with psychotic symptoms, etc. The other entity which may be a primary psychiatric disorder with psychotic symptoms, may be the late or very late onset schizophrenia, or there may be the presentation of persistent delusional disorders in the elderly, which is common in the elderly. Or the third may be the late onset mood disorder, especially the late onset depression in the elderly. From here, we can see those psychiatric disorder which present with the psychosis in the elderly are very few in number. The major chunk lie with the non-psychiatric disorders. What could be these non-psychiatric disorders? The major proportion shared are the one of the dementia, second is the delirium, third is the others. Others may be a number of physical and medical and drug-induced psychosis in the elderly. From this slice, this is very clear that majority of the psychotic symptoms are the presentation of non-psychotic disorders rather than the primary psychotic disorders. Hence, it is very important to look at elderly with what type of psychotic symptoms he is having. When we decided this is the non-psychotic disorder, then further in the psychiatric group, as per the ICD-10 and DSM-5, there is the number of psychiatric disorder, but these are very, very rare, and these share less than 25% of psychotic symptoms in the elderly population. The major chunk is shared by the non-psychiatric disorder, especially there may be the delirium, there may be the dementia, there may be the electrolyte imbalances and dehydration in the elderly, there may be the recurrent cerebrovascular accident, there may be the epilepsy due to the stroke phenomena, there may be a number of endocrine disease, the Parkinson disease and other neurodegenerative disease are common in the elderly and they present with the psychotic symptoms. There may be the number of medical conditions which increases the risk of psychotic symptoms. Even the diabetes, even the chronic uncontrolled hypertension also increase the risk of psychosis and delirium in the elderly. The Huntington chorea, CNS infection from encephalitis to meningitis, Creutzfeldt-Jakob disease, even the first presentation of CJD resembles psychosis. The PSP syndrome in the elderly, also metabolic encephalopathy, maybe the kidney-related metabolic encephalopathy, maybe the liver failure related, that is the hepatic encephalopathy. Drug-induced psychosis are very common in the elderly. Multi-system atrophy may present with the psychotic symptoms in the elderly. That means there are the number of non-psychotic entity or diagnostic groups which present with the psychotic symptoms in the elderly. What are the prevalence of these psychotic symptoms in the elderly as per the etiology? The most common etiology which generally present in our geriatric or day-to-day medicine OPD, about 40% presentation are of the dementia with the psychotic behavioral and psychological symptoms of dementia. The second group shared by the late onset depression, that is the mood disorder in the elderly. The third major group which presented the psychotic symptoms of the disease. The rest of the presentation may be a neurological or medical condition, maybe drug-induced psychosis, maybe schizophrenia, maybe delusional disorder. Hence, from this table, we can see the primary psychotic disorders accounts for only 1 to 3% of psychosis in the elderly population. That is the schizophrenia, delusional disorders, and maybe a late onset depression. The epidemiology of the psychosis in the elderly, there are the several studies. This is the older studies. As per this, up to 23% of the older adult will experience psychotic symptoms at some time in their lifespan after being old. The prevalence in the community dwelling elderly are 0.2 to 4.7%. The geriatric medicine clinic, the presence of psychotic symptoms are 15%. The geriatric psychiatry OPD, the presentation is more higher, 27%. In the nursing homes, the prevalence varies from 10 to 63%. Now, coming to the only the most common underlying risk factors are diagnostic groups which present with the psychotic symptoms. Especially they are the five group. The first is the dementia of all type, whether Alzheimer disease, whether frontotemporal, whether Lewy body, whether Parkinson disease, whether vascular, all present with the psychotic symptoms. The second group is the depression, third group is the delirium, fourth is the medication acceptance, and fifth is the infection in the old age group. In the dementia group, all the five type of dementia present with the psychotic symptoms. In the second most common depression, the underlying may be the late onset depression, vascular depression, comorbid depression associated with the neurodegenerative disease. In the third group, delirium, the most important risk factor is the aging. Second is the sensory losses. The third is the cognitive impairment. That means mild cognitive impairment or whether major cognitive disorder like the dementias, and more common in males. Coming to the first group, dementia, the characteristic of psychotic symptoms in the different type of dementia. Dementia with the psychosis, how this present. This is important to differentiate from the other underlying diseases. In the dementia, the psychosis and behavioral and psychological symptoms usually present in the 60 to 90% of the different type of dementia. They are either more common in the mild stage or in the moderate to severe stages. In the very severe stages, the patient become mute and depend and bedridden. Hence, they are the no psychology. Generally, they are the minimum psychological and psychotic symptoms in the very late stage of dementia. These psychotic and BPSD, different type of BPSD symptoms, they persist for prolonged period of time. And the very important is these symptoms or these psychotic symptoms are recurrent, episodic. The patient may present at one time with the psychotic symptoms. You treat, you find the cause, and the patient is totally normal for 6 months, 3 months. Again, he will land up with the symptoms of delirium. And this is very tough situation for either the clinician or for the family members and caregiver. Hence, in the dementia, the psychotic symptoms are may be episodic, may be recurrent, may fluctuate over the day and night. And the most important risk factors of psychosis in the dementia are the underlying neuropathological and neurochemical changes. The sensory impairment, whether auditory or visual, and the medication we are giving, treating the cognitive and non-cognitive symptoms of dementia. The comorbid medical problems and the associated treatment plan, the environmental changes in the patient with dementia, and the sleep disturbance in the patient of dementia. That means when the patient of dementia present with the psychotic symptoms, these risk factors should also be evaluated and should be minimized to decrease the recurrence of psychotic symptoms in the dementia. Taking prototype Alzheimer disease, which is the most common type of dementia, the psychotic symptoms are present over the different stages of dementia, Alzheimer disease in 50 to 70% of the cases. And what could be these? The most common type is the agitation. Without any reason, the patient is agitated. Patient may be aggressive. The patient may be abusive, may be hostile, whether physically, verbally. The second most common type of psychotic symptoms in the dementia is the delusions, which is usually present in 30 to 40% of the cases. The third most common type is maybe the hallucination. The fourth is verbal aggression, and the fifth is bonding. That means there are the various type of psychotic symptoms which usually accompany with the course of dementia. They are the list of psychotic symptoms: delusion, hallucination, misidentification, wandering behavior, irritability, catastrophic and catatonic reaction in the patient with dementia. Some patient would be keep complaining, some would be disinhibited, some would be intrusiveness, some would show negativism, some would bite, some would scream, some would be having the hoarding behavior. And with this, the psychotic symptoms fluctuate and it is very difficult to manage. And here, usually, the primary mistake is to calm down the patient by the either sedative or antipsychotic without identifying the target symptoms and the underlying cause of the target symptoms. Hence, when we know these may be different type of behavioral symptoms, psychological symptoms, and the psychotic symptoms, which may be associated with the dementia people, then we will be easily able to recognize and diagnose a category of psychotic disorder, like here would be the dementia with psychosis. The common of delusion in dementia patient, what they complain, they repeatedly complain that my home is not my own home. Take me to my aunt's home where my father is locating. Whether they have disease, still the patient would say that this is not my own home. They have even forgotten their real home, in which they are living for decades. There may be the presentation of delusion of threats. They will blame their maid that my belonging had been stolen by maid, by family members. There may be the complaint of infidelity, jealous over the spouses, over the family member. There are the complaint of misidentification of family member. There are the persecutory delusions. There may be the disinhibition, impulsivity, or lack of empathy. And these may be present here. You can see by number of plus signs. They are most of the common in the Alzheimer type rather than FTD, that is the frontotemporal, LBD, that is the Lewy body dementia, VAD, that is the vascular dementia, PDCC, that is the Parkinson dementia complex. In Alzheimer type, the delusions are more common, and in the other type of dementia, that are the subcortical dementia, the visual hallucination are very common, and they are present in 80 to 90% of cases of the Lewy body dementia, Parkinson disease dementia, and the personality changes and sudden anger outbursts. They are more common in the frontotemporal dementia. What the type of hallucination would be there? The patient would complain that he would seeing and interacting with people, animals, objects, and he would report of seeing their deceased spouses, deceased family member who are dead already, and they would say they have come, they are standing over there, they need foods, they would interact and communicate with them, and that is very problematic of the family members. By presence of these delusion and hallucination, which are more common in one type or other type of dementia, we can easily differentiate whether there is a strong probability of Alzheimer's dementia or frontotemporal or Lewy body or Parkinson's. For example, if a patient with dementia present with the recurrent visual hallucination, there is a strong possibility of Lewy body dementia or Parkinson. If a person present predominantly with the impulsivity and personality changes along with the memory impairment, there is a strong possibility of the frontotemporal dementia. If a person with present with the history of strokes and emotional instability and depressive symptoms, there is a strong possibility of the vascular dementia. In the Alzheimer type of dementia, the most important presentation is the loss of memory along with the delusions and other symptoms as shown in the important point over here that any type of behavioral and psychotic symptoms can appear at any stage of dementia and in any type of subtype of dementia, commonly during moderate stage. Multiple types of symptoms may occur simultaneously at one point. Coming to the next diagnostic group, which often present with the psychotic symptoms in the elderly, is the delirium. And this is also a very important topic. And the important uh, definition is that there is the acute reversible, this is acute reversible state of confusion characterized by changes in cognition and consciousness. That means the duration would be just weeks or days, and there is a sudden onset, and which leads to the fleeting and clouding consciousness. Usually, the delirium is recurrent and episodic if it is associated with underlying dementia. And the mortality is very high if a person develops the dementia. The mortality may be more than 20%. The important associated symptoms of delirium beyond the confusion and the clouded consciousness may be behavioral symptoms, maybe agitation, maybe psychomotor symptoms, and this psychomotor activation or hyperactivity may be such a high degree that patient need to be restrained. The second set of symptoms are disorientation and inattention. The patient may be confused about the day, date, time, and person, place. The third group of symptoms are the sleep reversal. There may be the sundowning phenomena, there may be the sleep reversal phenomena. Often the patient who is having the dementia symptoms, they present with the sleep reversal symptoms along with the clouding of consciousness. That means the patient of a dementia has developed episodic delirium. They may be the mood symptoms, the mood may be labile, and the rest, another set of symptoms may be the perceptual symptoms like the hallucination, like the illusions, thought symptoms like the different type of delusions, delusion of persecution, delusion of fearfulness. Every set of symptoms along with the all the higher mental faculty are clouded in the daily. The memory is also impaired. Coming to the next, this delirium is associated with the more than 20% mortality. Hence, of if a person present with the psychotic symptoms and we give a detailed workup and found out this may be a delirium, this entity is very important because in this entity of delirium, the mortality is very high. Even the prevalence in Delhi at the time of hospitalization is 11 to 24%. In post-surgical patient, in ICU setting, in CCU setting, the prevalence is very, very high high for delirium. And this is frequently unrecognized. Those patient of delirium who present with the hyperactive type of delirium, they are even recognized. But those who present with the hypoactive type of delirium, where the patient is in a stupor state, this is usually misdiagnosed and unrecognized. The most important factors for developing delirium is the advancing age. The second most important factor is the underlying dementia. The rest is the medical condition and the medication or substance use. Here's the list of common causes of delirium in elderly, and we all are well aware of various causes of delirium in the elderly. The 4-5 most important causes we often see in the emergency or in the licensed psychiatry setup for the elderly. The most important, if the patient is having the infection in the form of chest infection, that is the pneumonia. The second may be the urinary tract infection. The second group, which is very important, is the hypoxic condition, like if a person is suffering from COPD and have developed the chest infection like pneumonia, or there is some vascular illnesses like the pulmonary embolism during longer surgery, or in the common cold condition, the patient due to decreased capacity of lungs may develop the hypoxic condition and may have a confusion and some perceptual changes of the delirium. The third very important category, which is common, is the medication. And very important, very, very important, we often see the anticholinergic and anti-Parkinsonian medication. or when we give the excess dose of antipsychotics or benzodiazepines. This is also very important cause of delirium in the elderly. The other important cause is the encephalopathy of all the causes, electrolyte imbalance, and very ignored cause of delirium in the elderly is the GI causes. And two very important cause of GI symptoms are the chronic constipation, when the patient elderly will have the chronic constipation, or loose motion and dehydration. This will also increase the risk of going into delirium. Coming to the third group of disorder which commonly present with the psychotic symptoms in the elderly are mood disorder, especially the depressive type. And this depressive type is we know the most common psychiatric disorder in the older patient is the depression. And as per ECA community survey, which is very old, though, they the 27% of elderly are prone to develop depression. Am I audible? Should I continue? It is okay, sir.
Yeah, Dr.
Hello.
Jillani, you are audible. Kindly continue.
Okay. The most common psychiatric disorder in the older patient are depression, and the prevalence is 27% in the elderly. And we know in the elderly depression, late onset depression, there is the higher chances of developing psychotic symptoms. That means in the
Sima?
Amita, are you there?
Yes, sir.
Kindly see what's the problem. If you can
is
be
there
other,
any
yeah.
should I continue?
Yeah, Dr. Jillani, please continue.
Yes. Okay. That's the third group of the psychotic entity which presented the psychotic symptoms in the elderly. We know the most common psychotic disorder in the older patient is the depression, and this is prevalence. There is the high prevalence of late onset and the major depressive disorder in the elderly. And we also know that the prevalence of psychotic symptoms in the late onset or elderly geriatric depression is very high. That varies from 40 to 45%. And that is very important entity which present the psychotic symptoms in the elderly. And this geriatric depression is more likely to be associated with the medical conditions such as stroke, Parkinson disease, Alzheimer's disease, cancer, diabetes, and heart disease. This geriatric depression is also triggered by life events such as retirement, bereavement, social isolation, and caregiver stress. In the geriatric depression, there may be the psychotic symptoms in the form of delusions, which are usually mood congruent. There may be the different type of delusion like the persecurative, the common one are the persecurative delusion, somatic delusion, nihilistic delusion. And the content of all are usually they the feeling of guilt, sin, as someone has done some very big mistake. The hallucination are also mood congruent. Usually they are auditory, and the content is usually derogatory and cursing or sins. Coming to the other primary, what is the psychotic symptoms in the elderly, which are as the presentation of primary psychosis and primary psychiatric disorders? We know schizophrenia. We know there may be the early onset in the adolescence, onset of the 40 years of age, and very late onset as the onset of the 60 years of age. That entity is known as village. We know from this chart about 80% of the older adults with the schizophrenia, they are early onset type of the schizophrenia, and they are the patient of schizophrenia on the old age group who are progressing to old age following these various steps. The new onset type of very late onset schizophrenia comprise only 10% of all the cases. Hence, the incidence and prevalence of schizophrenia in old age and also the new cases are very, very less. In the late onset schizophrenia, usually the pre-morbid personality are preserved, the prominence of the positive symptoms, and the absence of negative symptoms. The predominance of positive symptoms, hence the clinical picture is dominated by hallucination in all modalities, and the systematic delusion, usually of the paranoid delusions. The disorganized and negative symptoms are usually uncommon. Coming to the one also very important group which may present with as a psychotic symptom disorder in the elderly are the persistent delusional disorder. And in this persistent delusional disorder, the persistent delusions without prominent hallucination in absence of dementia, schizophrenia, other psychiatric disorders. And usually the delusions are non-bizarre, well circumscribed and encapsulated. These may include belief about somatic illnesses, jealousies, persecution, theft, marital infidelity. The infidelity type are very common in Indian and Asian country and mistaken identity. Other psychopathology of the psychotic symptoms are characteristically absent in the PDD, persistent delusional disorder. What are the different medical conditions and drugs which are also responsible for psychotic symptoms in elderly? There are the number of medical conditions which present even their first presentation may be a delirium or confusional state. For example, chronic medical condition like the recurrent cerebrovascular accident, coronary artery disease, hypertension, diabetes mellitus, hypothyroid. The second group may be the nutritional deficiency, which are common in the elderly population, like all the vitamin deficiencies, dehydration, iron deficiency, anemia. The third group may be electrolyte imbalance. This electrolyte imbalance, especially hyponatremia, which may be either due to the some ongoing diuretics medication for hypertension in the elderly, or maybe due to the dehydration, vomiting, or loose motion. The hyponatremia is a very important cause of delirium in the elderly population. The fourth group of medical condition is the chronic liver disease, like hepatic encephalopathy. This also present with the delirium and other psychotic symptoms in the elderly. The fifth group is the chronic kidney disease, for example, uremic encephalopathy. The sixth group may be the Parkinson disease, multiple sclerosis. This group also present with the visual hallucination, or when we treat this group with the medication, their medication may cause the psychotic symptom. The other group is the major surgery, ICU care for medical illnesses, and the most common presentation in the major surgery and ICU setup is the delirium. The other group may be the COPD or pulmonary tuberculosis or any chronic illnesses. And here there may be the hypoxemia, respiratory causes, which may cause respiratory acidosis, alkalosis, and finally there may be the delirium and psychotic symptoms. What I want to show you here, every system of the body in the old age are compromised, and there's the higher risk of psychotic symptoms, even delirium, due to any systematic or system illness in the body. The last groups of which may be responsible for psychotic symptoms in the delirium are medicine and drugs. They the number of list, but what we prescribe in our day-to-day practice, there are the 5 group of medication which we often prescribe, especially the neurologist, neurosurgeon, and the psychiatrist. The first group is anti-dopaminergic agents. The anti-dopaminergic agents may include carbidopa, levodopa, pramipexole, ropinirole, amantadine, and these are dopamine antagonists, and there is a higher risk of developing psychotic symptoms due to these medications. The second group is the anticholinergic agents. Not only the primary anticholinergic agents, for example, trihexyphenidyl, but many of the traditional antipsychotics like haloperidol, chlorpromazine, they are having higher anticholinergic activity, and that may also be responsible for anticholinergic activity and delirium picture in elderly population. The other medication may be the overdose of antipsychotic medication or those antipsychotic medication which are associated with higher antihistaminergic activity, higher anticholinergic activity. They are having more risk of developing delirium in elderly, especially the hypoactive type of delirium. The antidepressant, especially the SSRI, they may cause hyponatremia, SIADH, and may land up patient into the delirium. The benzodiazepine and other sedative, due to excess sedation, the patient may develop the hyperactive delirium. That means all these 5 group of medication along with the other group, I am not going in detail, the antihypertensive medication, the anti-cancer medication, which are also responsible for psychotic symptoms. These are the medication we commonly prescribe and commonly see as a cause of the psychotic symptoms in elderly population. And they may cause visual hallucination, paranoia, hypoactive delirium, hyperactive delirium, and sleep reversal in elderly population. Coming to the next slide, this is the number of medicine. Everyone knows. Coming to the management. Before this is the last few slides. I am not taking much of the time. Here, I would just like to summarize. They are the primary psychiatric disorders and primary psychotic disorder, which may have a presentation of psychosis in the elderly. But this psychiatric disorder are not very important for our psychotic symptoms of elderly. They are the non-psychiatric disorders and medical condition and medication, which are more important and more common cause of psychotic symptoms in the elderly population. For this reason, the management include a complete history of present illness, the comorbid medical history, the continuing medication, which the patient is taking, and in every elderly, the brief cognitive testing is very important to level the underlying cognitive impairment, which is independent cause of psychotic symptoms and the delirium. The sixth very important in the history taking is rule out delirium in every elderly patient. Rule out delirium in every elderly patient. There is a higher chance of delirium than the primary psychiatric or psychotic cause of psychosis in the elderly. In every elderly patient who present with the psychotic symptoms, the blood investigation and neuroimaging are routine test. This is not if required. This is routine test in every elderly patient. The complete history will give you easier tips to differentiate within primary psychotic disorder, psychotic symptoms with other psychiatric disorder, substance use psychotic disorder, psychosis associated with delirium and dementia. The medical history which reveals comorbid physical illnesses, and the medication history which give us important note down current medication, change in medication. The routine medical investigation in elderly are CBC, blood glucose level, even an episode of hypoglycemia in diabetic elderly patient who have taken overdose of anti-diabetic medication. Due to hypoglycemia or hyperglycemia, they may land up in delirious-like condition. The kidney function test, which reveals the electrolyte and the creatinine, liver function test, blood lipid profile, liver function test, thyroid profile, iron and vitamin profile, urine analysis. UTI is also a common cause of the delirium in elderly. Chest X-ray to rule out chest infection, CT head and MRI. This should be also a routine investigation in elderly on the basis of higher suspicion. When the elderly present and history revealed that the patient had a fall, the fall may cause the SADH or EDH, and which may present as a delirious patient. After this, we have to reach on the primary diagnosis, whether the primary diagnosis, the primary psychiatric disorders presenting with the psychotic symptoms or non-psychiatric disorder presenting with the psychotic symptoms. With the assessment of comorbid diagnosis, comorbid physical diagnosis, if there is any investigational abnormality like hypoglycemia, hyponatremia, higher infection, and what the patient concurrently taking medication. The most important aim to treat the patient with psychosis is the safety of elderly as they are fragile. The second important aim is the symptom-based treatment. The first is the safety. The presence of psychosis is not necessarily an indication of antipsychotic medication. The presence of psychosis may indicate a very, very common underlying cause, and treating that underlying cause may resolve the psychotic symptoms, and there may not be need of any antipsychotic medication in that particular patient. The various point, if I am skipping this slide, we all know that all the system of body of elderly are compromised, and that is important reason that we should give a smaller dose of drugs if needed, and as possible as we have to avoid the medication. If the patient present with the psychiatric disorder with psychosis, the treatment would be as per standard guideline as in the adult, but the dose would be 1/4 to start. This is very simple. But in the second group, when the psychosis present with the underlying neurodegenerative disorder, the psychosis is the part of delirium, the psychosis is the part of some medical condition. In this major group, the important point is the identification and treatment of target symptoms and the disorder. The second is the identification and management of modifiable and non-modifiable risk factor for psychotic symptoms and delirium. If in this we may use antipsychotic medication, we may use benzodiazepine and sleep regulator for agitation or sleep disturbances. We have to treat the underlying causes. In the other medication which is also helpful is the dementia medication, acetylcholinesterase. If there is the underlying neurocognitive deficit, even if there is no underlying neurocognitive deficit and no there is the physical cause, the patient just presented with the recurrent delirium, in that condition also, the acetylcholinesterase and the NMDRA receptor antagonist, they have important role beside the antipsychotic. What I want to emphasize here that antipsychotic medication are not only basic treatment of psychotic symptoms in elderly. Even the cognitive enhancer play important role in prevention and treatment of psychotic symptoms in the elderly. The atypical antipsychotics, especially there are the four antipsychotic which are commonly used in the geriatric population: risperidone, quetiapine, olanzapine, and eripiprazole. There is the very strong evidence for risperidone, and the second very strong evidence for quetiapine. There is the side effect profile of these all four. We all know that what is the side effect profile for risperidone, quetiapine, which is more commonly causes the hypertension, olanzapine. This is also have some side effect profile, eripiprazole. All are equally effective. We have to start from 1/4 of the adult doses and reach to the where there is the proper response. There is no very hard and fast guideline, or even what I want to emphasize over here that their psychosis is more common and more problematic in elderly population, but not a single antipsychotics or especially FDA approved or some approved by some major guideline for the psychosis in delirium or dementia until unless they are not a primary psychotic disorder. Even a black box warning associated with these atypical antipsychotic disorder that they increase the mortality and there is the higher chances of the vascular event in the elderly population. as I said earlier, that cholinesterase inhibitors, they also have some antipsychotic effects. They are helpful in mild to moderate severity of psychosis associated with dementia. In Lewy body type of dementia, psychosis better respond with the cholinesterase inhibitors. Hence, we should avoid antipsychotics. There is a high risk of Parkinsonism and delirium in the Lewy body of dementia or Parkinson disease dementia complex. In frontotemporal dementia, antipsychotics are not very helpful because the personality changes more common in frontotemporal dementia. Even the sleep regulator like the melatonin, this also improve the sleep, suppress sundowning, and somehow improve the confusion and delirium in the elderly population. Many of the cases of elderly with the psychotic symptoms do not respond with the antipsychotic medication, and we keep on increasing the dose of antipsychotic, or we keep on changing the antipsychotics from one group to another group. But in that groups, they also response with the anti-epileptic medication, especially the sodium valproate. And what has been seen? It has been seen that there is the higher prevalence of EZ, electroencephalographic abnormality in dementia delirium. Hence, they better respond with the anti-epileptic medication than the antipsychotic of medication. With this, I would like to finish the presentation, and they are the 4 case summary. And with the permission of chairperson, there are just 4 cases. I will just finish in 4 minutes. The first case is the 70-year-old male elderly, who presented with the delusion of persecution with the altered sleep cycles and behavior for the last 10 days. The history reveals absence of any primary psychiatric disorder. The medical history reveals pulmonary tuberculosis for last 1 month. The medication history reveals the anti-tubercular medication for 3 months he is taking. What would be the cause, diagnosis, and cause of this delusion of persecution and behavioral changes in this patient? From here, it is very clear that the patient was not having any primary psychiatric disorder, not having any cognitive impairment. But when he was diagnosed with the pulmonary tuberculosis, and after when he was started with the anti-tubercular medication, he developed delusion of persecution along with the sleep cycle reversal for the last 10 days. For this, we get the licensed psychiatry reference in the medical college, and the cause is very simple. This may be a isoniazid-induced psychotic disorder, like the primary psychotic disorder in the elderly. Similarly, the second real case which I had seen is the 65-year-old female elderly who presented with marked agitation, crying spells, sleep disturbances. The history of presentive illness revealed duration of illness for last 3 weeks. The stress were in the form of quarrel and police case of her husband with the neighbor over the issues of land. MSc revealed delusion of persecution that the neighbor are planning against her family. The blood investigation revealed hyponatremia. There is no past history of any psychiatric disorder, any medical disorder, or any cognitive impairment. What would be the diagnosis? The third case is a 60-year-old male who presented with the sudden onset of hallucinatory behavior and forgetfulness for last 5 days. He was suffering from history of present illness revealed visual hallucination in the form of his distant relative have come to harm them. They are hiding on the upper floor of their home and they are abusing him. His sleep was disturbed. He was markedly agitated. The medication history revealed that he was well maintained on tablet Syndopa, tablet Premirol, tablet Clonazepam for last 3 years for idiopathic Parkinson disease. What the family member noticed that for last 3 months, despite the above medication, the tremors and gait coordination was increasing day by day. Hence, his treatment was revised by his consultant last week. A new medication in the form of tab trihexyphenidyl 2 milligram twice a day was added. After adding this, he developed the visual hallucination that his distant relative who have died, they have come in their home and they are trying to harm him. They do no history of cognitive decline. They do no history of other psychiatric illness, and all the relevant investigation are within normal limit. What would be the diagnosis and what would be the probable cause of psychotic symptoms in this patient of Parkinson disease who was well maintained on anti-dopaminergic agents? The last case is the 69-year-old male presented with the complaint of that he would repeatedly ask his family members that take him to his own home. His father and siblings are waiting there, and father and siblings are all have died because this 69-year-old male. Further history revealed that the first symptoms were in the form of forgetfulness in day-to-day routines for last 3 years. Information from other family member that he would call his wife as mother. That means he is misidentifying his wife as a mother and could not recognize his grandson and daughter. Should also repeatedly blame his maid for stealing his belonging. The brain investigation are within normal limit. MRI brain revealed diffuse cerebral atrophy. What would be the diagnosis? With the permission of chairperson of this CME, I would like to stop my presentation and give hand word to chairperson for further question answer and discussion on these 4 cases and this topic. With due respect, hello, ma'am, sir.
Thank you, Dr. Jillani. Dr. Pramod, shall I take over? Thank you, Dr. Jillani, for that really, really detailed overview of psychotic illness in the elderly, which you managed to cover with a span of really 45 to 50 minutes. And as Dr. Jillani has talked about both the organic and functional causes of psychotic disorders in the elderly, things which we see very much in our day-to-day practice, both in the clinic as well as in hospital. And all of this is really important for us to be aware of while we see the elderly, especially with the psychotic disorders, which can be the first presentation in an elder person presenting to clinic, coming just as confusion, which can be because of physical causes, which should be the prime and foremost thing before we think of any diagnosis. Rule out all physical causes. If possible, look at scannings and then look at any recent medication history. And of course, the 4 detailed vignettes, case vignettes, a classic example of how we should keep in mind simple things like, antibody-induced psychotic disorders. And of course, the other one was the typical case of delirium from hyponatremia, and perhaps also differential diagnosis of acute stress reaction, something to keep in mind. And the last one was perhaps most likely case of Alzheimer's, considering history as well. So these are very useful scenarios for us and very, very helpful. And I'm sure the audience has had an interesting understanding of psychotic illness in the elderly. So with all of this, I would now like to go on to any questions from the audience. So we have a question from Dr. Hadia Kha, who's asked, how do antipsychotics cause psychosis?
Yes, yes. This is yes. This is very important question, and I was expecting this that how does antipsychotic cause psychosis in the elderly? Antipsychotic not only cause psychotic symptoms, especially the delirium in the elderly, but also in the adult years, especially the atypical antipsychotic agents. We know that atypical class of the antipsychotic agents, they are associated with the higher anticholinergic activity, which is maybe responsible for delirium, higher antihistaminergic activity, They also associate with the higher anti-adrenergic activity, but the anti-adrenergic activity is not responsible for delirious picture, but the anticholinergic activity which impair the memory, which causes the confusion, and the antihistaminergic activity of antipsychotic agents, which causes the sedation. And this sedation, anticholinergic confusion, disorientation, and memory impairment, they cause delirium-like condition or delirium-like picture in the elderly if we give in the higher dose than the adverse. The basic problem is that when we start with the low dose, the patient complains that patient is not responding, not sleeping, still he is repeatedly showing his delusion. When then we increase the dose of the medication very fast. In that condition, the anticholinergic and antihistaminic activity causes the delirious and excess sedation in the elderly, and that is basically a delirium caused by the antipsychotic agents.
Thank you very much, Dr. Jillani. May I also add that in some cases we might
Yes.
see blocking of the dopamine D2 receptors, which may present as a compensatory state of
Yes.
supersensitivity, which could be, most common presentations like tardive dyskinesia and other presentations like that, which could be some form of a supersensitivity psychosis as well. So that's probably the only other thing which would come to mind considering antipsychotic induced psychosis. Any other
Very true.
questions from
Very
the
true, ma'am.
audience? So I think there is another question from Dr. Colin Braganza. Which would be a better choice for addressing disturbances and sleep disturbances in a patient with dementia with BPSD? Melatonin 3 milligram or zolpidem 6.25 controlled release if sedating antipsychotics can't be used due to medical comorbidities. And I think the second part is also, what would you prefer in delirium in a similar case with altered sleep-wake cycle?
I think you would be in better position to give the answer of this question, ma'am.
Yeah. So basically, sleep disturbance, altered sleep-wake cycle is a very common presentation in dementia. So ideally, it would be useful to kind of find out what we tend to see in our daily structures. In addition to pharmacological, we should always think of non-pharmacological interventions or patterns as well. So what is the day-to-day structure of this particular person? What is his day-to-day habits? Because a lot of the time, patients tend to sleep during the daytime. They have long patterns of sleep only because there's no stimulation, there's no cognitive stimulation, or there's no daytime stimulation. Most of the time, families are happy for them just to be at, within their room. And I think one of the things that we have to time and again tell them is make sure that they minimize their sleep pattern so there is no sleep wake, the sleep wake reversal is corrected. And after all of that, which we need to kind of patiently explain, trying to really educate the families and carers, and if there's a nursing home, give a trial of that period. And if this sleep disturbances persist, then perhaps look at what are the other causes are there any medications which may be hindering the sleep, so try and correct that. After correction of all of that, there are trials and studies to say that there are some medications, like, for example, if there are any visual hallucinations, if there is an Lewy body dementia kind of picture, there is a high kind of evidence for antipsychotics, low dose antipsychotics, specifically quetiapine. And I would look at a very small dose, 12.5 milligrams to start with. So look at what things like that, to look at what the specific type of dementia is, and then trial with that and just see if that helps. And perhaps then look at other alternatives. And if that all of that doesn't work, then perhaps go on to medications like melatonin or zolpidem to start with, because if we need something like LBD, it would cover both the visual hallucinations as well as the sleep disturbances, rather than combination of the two. And I guess, again, coming to delirium as well, again, just like how Dr. Jillani explained to us, it's very important for us to identify the cause of delirium, first of all. If it's specifically related to any medications, identify all of that. And if sometimes if the patient is in in an ICU or a hospital setting where it can be disturbing to the other patients, then look at the extent and the severity of the disturbance. Because sometimes it's how much is tolerable to the patient and to the carers, and based on that, then we again look at I would look at similar quetiapine has some evidence as well for delirium, especially if there's visual hallucinations as well. And if that doesn't work, ideally it's better to refrain from using any benzodiazepines. That is what the guidelines say, only because of rebound phenomenon and perhaps increasing the confusional states. So would you agree with that, Dr. Jillani? So
yes, sure. Sure, very true, ma'am. Basically, in each and every case is different literally, and we have to reach one by one, and that also depend on the what is the probable cause of that particular symptoms. That is the identification of target symptoms and the identification of the underlying cause of that target system. That may be a very common cause, maybe a constipation is causing a sleep disturbance in that elderly patient, but we are not focusing that patient is having a constipation or not. That is what ma'am said. That is very important. Search out the cause, then go for the medication. If needed, we can give quetiapine, we can give olanzapine, we can give any other antipsychotics. All are efficacious. But the very important thing is that start, don't judge the severity of symptoms and give as the adult dose that the symptoms are very severe and we have to start from the higher dose. They start from the very low dose. That is very important.
Thank you, Dr. Jillani. Are there any other questions from the audience?
I think Dr. Majid sir is there and he will give his expert advice regarding this topic, and we would request him to give him his expert advice, especially the overall view.
Yeah. Before I start, I think we have a question and somebody has raised his hand. He can unmute himself and ask the question, please.
Good evening, sir. So I have a doubt. So in the case of bipolar disorders or any other psychotic disorder which needs long-term drug initiation, sometimes over the period of years they develop drug-induced Parkinsonism-like symptoms. So in that case, like how can we manage?
So I will request Majid sir to answer this question, please, sir.
I didn't get the question. Can you repeat it, please?
No, sir. Like a patient who's already on antipsychotic, like when they cross around 50 or something like that, they develop sometimes drug-induced Parkinsonism-like symptoms, and sometimes even they persist even after dose reduction or initiation of anticholinergics or something like that. In that case, when we are in a position to treat the individual Parkinsonism also, in that case, which are the antipsychotics which are safe, and how can we proceed with the case?
Yeah, the patients who have Parkinsonism associated with dementia or even with psychosis, ideally, we use quetiapine, which is recommended because of its profile, the receptors which it acts on. And there is some data that supports that clozapine also could be used in such patients. To my experience, I think quetiapine would be number one. And number two, clozapine, if sleep is also disturbed, then clozapine could be another choice because the EPS is quite less with clozapine. However, in elderly, clozapine has to be used with a lot of caution because of the comorbid medical conditions and the concomitant medications that the patient would be taking at the same time. If Dr. Shiba, Dr. Jillani could add on that.
Thank you, Dr. Majid. I absolutely agree with you. I think first line would be think of something safer like quetiapine, which has probably got low EPSCs and low risk of tardive dyskinesia, considering it's an elderly and perhaps a sex of the patient as well. I'm looking for any comorbidities. Clozapine is also something that we tend to use, and perhaps another one would be olanzapine, which is probably got, again, depending upon the diabetic history and things like that, it would be useful to look into that as well. And also, yeah, those would be the first two choices. And then as Dr. Majid has just said, thank you.
Any other question from anybody? Because I think we are running late, and Dr. Jillani has presented a wonderful, exhaustive, very elaborate presentation. It's a very difficult sort of a topic, but I think he has done more than justice, one would say, to the topic by doing it in a very short period of time. And I think it was very, very informative. Any other question before we conclude? Yeah, I think there is no question, and it's my privilege to present vote of thanks to the speaker, Dr. Jillani, who has, as I said, done a wonderful job of teaching us today. And Dr. Shibab, you have been equally very good with the moderation and your inputs. Dr. Pramod Kumar, who is the Vice President, thank you very much, sir, for being there. Dr. Nitin Gupta, who actually started the program with welcome address. Thank you, Nitin, sir. Most importantly, the team which has actually conceived this idea of Friday's CME series is Dr. Yossi Garg, the president of Indian Association of Biological Psychiatry, Dr. Sheda Saida. She is not today. Normally, she would moderate the whole session, but because of some unavoidable circumstances, she could not be present. And Dr. Sunil Mittal, Dr. G. Prasad Rao, Dr. Prasanjit Tosh, who is our treasurer, and Dr. Alim Siddiqui, who is the editor. So it's a team effort always. And thank you all for being there, and thank you delegates or the participants who have been very active throughout this session. Although there are a lot of parallel sessions going on, and we hope that we'll have a next Friday CME series with some different topic and some very interesting a topic and a speaker. And Amita from MediSquare, thank you very much for being in the background. There were in between technical glitches, I think, but we managed it well. And most important, that it was very informative. Thank you all, and we'll see you soon in the next session of Friday CME series in next couple of months. Thank you all, and good night. Take care.
Good night. Good night, sir. Good night, ma'am. Good night, everyone.